Welcome back to Over 50 and Flourishing. My guest today is just an absolute treasure. She's a treasure from the sea. She's just from down south here in Galveston, Texas, about 50 miles away from Houston, but she's just a wonder when it comes to, oh my gosh, all things HRT, menopause, living your best life in midlife. She's written the book, The Galveston Diet, which we've been focusing on the first half of this podcast. I really want to shift the attention now to menopause because that's really where she became viral on TikTok and Instagram and how all of you got to know her. And I love this conversation about menopause, and it's so open and fresh, and your audience, my goodness, so receptive. I see I follow the comments, I see all the questions that you're getting. Mm-hmm. It's such a game changer. And, you were among the first to really get this out there and be a mouthpiece for something that we all go through. And so your history, your backstory is you were practicing OB-GYN. Mm-hmm. And, I've heard, and correct me if I'm wrong, you get maybe when you're training, maybe a day in menopause training.
So in medical school, you might, now again, I went to school 30 years ago. You might get it, we got maybe an hour lecture in endocrinology on menopause.
That's it.
And it was the end of your periods.
And that's it. Carry on.
So,
wow.
Yeah. And it was always framed in terms of your fertility. Mm-hmm. And, I did not understand the ensuing health risks until I started on my own menopause journey.
Yeah.
Other than osteoporosis. I knew that one. Right. In my residency, and now I'm also speaking as a former residency program director where I was in charge of the curriculum. So until 2018 or 2017, I know exactly what the residents were required to be taught. Now, there was some didactic, meaning lecture type things that we were required to cover, but there were no menopause clinics or focus time dedicated to the care of the menopausal woman, and forget perimenopause.
Right.
There was nothing taught about the nuances of picking it up, how to diagnose it, how to treat a patient who's suffering. And so when I graduated from my training program, I can deliver a baby upside down, backwards, inside out. I can take care of a pregnant woman. More than half of my training was spent on obstetrics, which is all important. Yeah. I learned amazing things about oncology, ovarian cancer, cervical cancer, uterine cancer. I learned all kind of surgical techniques, laparoscopic, open, vaginal, to do all these different gynecologic surgeries, reconstructive surgery of the pelvis for prolapse. I learned pediatric gynecology. So obstetrics took up 55, 60%. And then gynecology gets shoved into the box with everything else. And then you have a lot of time in the OR to learn how to do these very important surgical techniques. You have tons of time on oncology because it is so important and so complicated. Pediatric gynecology got a little sliver, and then menopause just gets whatever dust.
just a little fairy dust that got sprinkled.
is left. And I thought nothing of it at the time. I remember, so I'm going to be super honest and raw here and tell you something that is 100% true and I'm so ashamed of. So there was a code for a woman that I now realize was perimenopausal and menopausal. It was a woman who came in with a lot of vague complaints. Mm-hmm. She wasn't sleeping. She was gaining some weight. She was a little bit depressed, maybe anxious. She was hurting in places. Mm-hmm. Nothing you could put your finger on, nothing like that hit a checklist for a common medical condition. And we had a name for it. And it wasn't anything written in a book. Our professors never said this, but it was something kind of passed down from the upper level residents to the lower. And it was a WW, a whiny woman.
Oh. Isn't that something?
And it would, I thought nothing of it.
Right.
It's so shameful to me that I propagated this, and that was a part of it. And that we completely, if we couldn't figure it out, it was in her head.
Right.
It's all in her head.
Many women were put on antidepressants going through menopause.
Now, some antidepressants actually do help with hot flashes, some. So I see where if you're terrified to give a woman hormone therapy because you'll get sued if she gets cancer, that may be an SSRI. But like this blanket recommendation of an antidepressant for menopause treatment is just outrageous to me now. And so we have to change this mentality. And this is part of how society views a menopausal woman. How, have you seen the latest memes about the AI? You ask AI to draw a menopausal woman and it's this scary looking witch.
Frazzled.
Frazzled and like in her 80s.
Yeah.
And so I'm like, no, we're
not
vibrant and strong. And I'm at the beginning, I'm like more successful than I've ever been in my entire life. I'm helping more people than I ever have in my entire life. And I'm a menopausal woman. And we've got to change this narrative so we can, it's a big ship to course correct, from society to how we train our providers to how the medical world and everyone thinks about this time of our lives. But it doesn't have to be this horrible time of suffering where we are no longer have any value left to society or the medical community.
You and I are both having this conversation and this passion about it, even though coming from two different backgrounds, you the medical side, me from just a woman who went through menopause, but also as a broadcast journalist, wanting to get the experience out there because my menopause experience was so brutal and caught me by surprise because I'm that type of person. I always felt good. I never had bad periods. I never had problems. I'm just happy-go-lucky kind of person. And it absolutely blindsided me in my 40s. All the things that you talk about, the sleeplessness, the irritability, the moodiness, feeling somewhat depressed. I'm like, what, me? I'm always smiling. I'm always the optimist. And now I'm feeling like I'm on a sinking ship. Things that I just didn't understand. And I didn't, at that time, I was seeking some help and I was getting some therapy, but now I realized that what I was getting wasn't enough. And it was just progesterone, and the lack of estrogen in my body was really what was triggering all of that to happen. And so it came in late for me. Thankfully, it came in. But I want to start with perimenopause because really that's where it all begins. That's when we feel like we are starting to absolutely break down. And there are physiological reasons for why all of this is happening.
Right.
So explain to women what is going on in their body.
So let's start with some basic definitions. So, and a lot of this is really misunderstood. Menopause is one day in your life.
Right.
It is 1 day after 1 year to the day after your last menstrual period. So it signifies a lot of things.
Yes.
Perimenopause is the time period between that day and your normal, the end of your normal reproductive cycles. Okay. When I say normal, when the estrogen depletion wasn't really affecting your body yet.
Right.
Okay. And then postmenopause is menopause till you die.
Way on.
Until you're done.
Right.
And perimenopause can begin 7 to 10 years, like the effective perimenopause in your body can begin 7 to 10 years before your period stops. So if the average age of menopause is 51, but normal is still 45 to 55, you can be as early as 35 and begin your perimenopause journey and begin having symptoms when almost uniformly patients are being told, you're too young.
Right.
You're too young. It's impossible. And that's just not true.
Right. So what happens to that woman who, let's say, is in her late 30s or early
and
40s and thinking, this is not me?
I think I was told in med school and residency, but it just didn't really register. And I remember reading it again like a few years ago and being like, now it makes sense. So we are born with all of our eggs in our ovaries, okay? They actually form in utero, and we hit our maximum egg count at 20 weeks. So when your mom was 5 months pregnant with, our mothers were 5 months pregnant with us, is when we had the most amount of eggs, okay? And they start declining at 20 weeks. So they're declining from the day we're born, they decline all through puberty, and then you start ovulating. So by the time we hit 30, we're down to about 10% on average of the egg, of the follicle count.
Right.
By the time we hit 40, we're down to 3%. And so the symptoms of lower estrogen kind of depends on genetics and environment when you're going to start feeling that, or when your body's going to start registering, hey, estrogen depletion. It's getting really hard for me to get my estrogen levels up. Like there's just a few eggs left and they're all holding hands, trying their best.
Stay
but
together.
The egg quality, and then because
Right.
we're born with those eggs, the quality of those eggs, their ability to like produce estrogen
and be viable.
and be viable begins to decline as well. So once that last little egg kind of dies off,
Yeah.
then you start replacing all of the stroma in the ovary with fibrosis. And so eventually your ovaries will basically, after several years of menopause, be undetectable. You won't even see them.
Wow. So how does a woman know that this is even going on? And
It's a great question.
and she's
And
probably
this is
thinking, is it too early to even seek treatment?
So because we have almost no studies done in perimenopause or no uniform way to diagnose perimenopause, that's a good question.
Seriously.
So there's not unfortunately, we do not have a blood test that, or a urine or a saliva test that is going to accurately diagnose perimenopause. The hallmark of perimenopause is decreasing rates of ovulation. So where you used to ovulate, now if you have polycystic ovarian syndrome or you don't ovulate, good luck, because they look very similar, to each other. So a one-time blood test might pick up that you're not ovulating regularly. It might it usually looks totally normal, and your doctor's like, you're fine, this isn't menopause. It's not menopause, which is
perimenopause.
the end.
Right.
So perimenopause right now is diagnosed clinically. You have to listen to the patient. You have to believe her. You may do other blood work to make sure that there's not other conditions that look the same, like hypothyroidism or not other autoimmune disease or anemia or a nutrition deficiency, which is what I do in my clinic. And then you start treatment.
And that treatment would look like what?
So it depends. Again, an art here rather than so much of a science, because we don't have a lot of studies.
Yeah.
So when we talk about support during perimenopause, we're giving you back estrogen and progesterone that your body's not making on a normal, regular basis. That could look like a low-dose birth control pill for some women, especially if she's also having cramps and really heavy periods or acne associated with her perimenopause. We want to suppress ovulations. In order to do that, we need a higher dose.
Right.
Menopause therapy doses, remember, are just meant to give you the health benefits and get your symptoms at bay, which is a percentage of the dose of that's in a birth control pill. And there's not a lot of difference other than some chemical formulations of what's commercially available between the two. So when I talk about perimenopause, we're usually talking in higher doses because we're trying to sometimes suppress ovulation. If it's at the end of perimenopause, we could just go ahead and start menopause dosing treatment in the lower doses, because we're just trying to get you back up to a baseline level.
Yeah. I think for me, the biggest mistake, like I said, was only progesterone and not getting the estrogen
And
when I
progesterone
need
can
it.
help some of the symptoms.
Yeah.
It can help with sleep. It can help not so much with hot flashes, but it can help with some anxiety at night.
Yes.
But really the thing that's going to help the most people almost all of the time for the most symptoms is going to be estrogen.
Yeah. There are so many different types of HRT out there. There are patches, there are pills, there are creams, there are pellets. I mean, and as I've come to find out, Oscar's going to join the podcast. As I've come to find out, it's not one size fits all.
No.
I mean, I got a patch here. I take a progesterone capsule. I've got a testosterone little pellet.
Yeah.
It's like a little bit of everything.
Right.
So how do you kind of figure out that magic formula per woman?
Great question. So when we look at, there's different ways to get it in your body. And then there's different formulations of how to get it in, So I try to stick with the FDA approved, regulated options, because I know there's a 98% chance of what they say is in that box is in that box or in that pill, if it's regulated. If we're going with a compounded option, then there's a lot of hit or miss, flexibility. You have a little more prescribing flexibility, but it just depends on who's behind the counter and what they're putting in there.
Sure.
And, we do see when it's tested, there's a lot more variation coming out, on that end. So we have oral. So let's talk about estrogen first. Sure. We have oral and non-oral. Oral works great. It gets your bones stronger, helps the general urinary system. It does all the things medically. but there are a little bit higher risk with it. Oral has a higher risk of blood clots because of the first pass effect in the liver. So when that bump of estrogen hits the liver, comes through the gastrointestinal tract, everything we eat and ingest goes to the liver for processing, as I point to my liver. So we do see a slight uptick in the clotting factors. And so for 7 out of 10,000 women will have a blood clot who otherwise would not have over her baseline.
Okay.
So by choosing a non-oral option, such as a gel or a patch or maybe a cream, we can negate that effect. So a lot of women who are under the assumption or were told by someone who hasn't kept up with the literature, you're not a candidate because you have this family history of clotting or you've had a blood clot, you actually might be a candidate.
Yeah, you're just saying it's the delivery system.
It's the delivery system of the estrogen. That's the problem. The progesterone, most people who know what they're doing are doing the oral micronized progesterone. Progesterone in a cream form is a very large molecule. It's not readily absorbed through the skin. There's a lot of, it's really hard to get at high enough levels to protect the endometrium. So we would never recommend a cream for progesterone if you're taking estrogen at the same time because your risk of endometrial cancer is higher. So, and when there was a great study out of France, I think they had 80,000 patients they looked at. It was an observational study, and they looked at the type of progestin that they were on and the risk of breast cancer, because it does seem like it's the progestin and the HRT that causes that is linked to breast. I don't want to say causes.
Yes,
that is linked to breast cancer rather than the estrogen. That oral micronized progesterone had very little, if any, increased risk. It seemed to be the safest version.
Yes.
So most people in my world who follow the evidence are recommending the oral micronized progesterone.
Wasn't it, back to that study, was it the NIH study, which was the one that
The
had...
WHI, the Women's Health Initiative,
WHI.
that was put on by the NIH, yeah.
Got it. And that was one that had progestin in it, correct?
Yeah, so they only looked at Premarin and Prempro.
Yes.
Which were the top prescribed forms at the time.
Yeah.
The compounding industry hadn't taken off at that time, so most women were getting Premarin or Prempro. And so...
Did it come from horse urine?
So Premarin stands for pregnant mare urine. And so they were extracting the estrogen from the urine of pregnant mares. I don't prescribe that. Not that I don't think it works well, I just have ethical problems with how they extract it. I've come from a horse-loving family, and I have other options for my patients that work amazingly well without torturing a horse, so that's what I do.
Got it.
I lost my train of thought.
The progestin.
Progestin.
Yeah.
So the progestin in it was medroxyprogesterone acetate, which is Provera. And it was the patients who took the Provera, not the estrogen-only arm, that had the increased risk of breast cancer, even though they were at a much lower stage and had a higher chance of survival versus placebo patients who were diagnosed. And so I avoid Provera for that reason.
Right.
And oral micronized progesterone is body identical. It's non-synthetic, and it seems to have the lowest risks associated with it. So that's pretty much all I prescribe.
Yeah. It's interesting because whenever there's discussion about HRT, whether I see it on your end or I talk about it, it's inevitable. The comments of, I don't do it. It increases the risk of cancer. Why put yourself at risk for blah, blah, blah. What's your take on this? And I know what your take is, but go ahead and elaborate. And is there somebody who truly isn't a candidate for any of this?
Absolutely.
Okay.
There are always medications that certain people with risk factors. So we have absolute contraindications to estrogen, to progestin, to even testosterone. So in the HRT family, when we say HRT as obstetricians and gynecologists in the health profession, we are only talking about estrogen plus or minus progesterone. Testosterone it is hormone therapy, but it falls into a different category. So we'll talk about that separately.
Right.
I lost my train of thought again.
Menopause.
Menopause.
So who wouldn't be a candidate?
Contraindications.
Yeah.
Thank you.
You're welcome.
So absolute
I'm just glad
contraindications.
that
If
this is
you have
functioning.
undiagnosed vaginal bleeding,
Okay.
so you are having not normal periods for you,
Right.
You should not be on hormone therapy. You need to go get that evaluated and treated because we could be feeding a cancer.
Got it.
Got it? If you have active breast cancer, that needs to be evaluated, treated, managed before you ever consider hormone therapy or even if you're a candidate.
If somebody's had breast cancer in the
It
past.
depends.
Okay.
It's a very individualized decision. It really depends on what stage, what type. But there are people who are breast cancer survivors who are successfully taking hormone therapy.
Okay.
Now, they may have had mastectomies and oophorectomies and,
Yes.
but I know OB-GYNs who've had breast cancer who are taking hormone therapy successfully, very low dose.
Okay.
But again, very, very one-on-one individual decision
It's
making, not a blanket
statement
recommendation
at all.
There are people who have had a active blood clot or a clot in the last 6 months who stop everything until we figure this out, what caused it, and then reevaluate later to see if you're a candidate.
Right.
Blood pressure, elevated blood pressure is not a contraindication. Matter of fact, the American Heart Association just came out with recommendations showing it was oral estrogen, not transdermal,
Right.
that increased the risk. So, people who've been walking around their whole lives to saying, I can't take it, I've been told I can't take it, my sister had breast cancer, this is not true. So, and you need to find someone who's versed in the latest recommendations and studies and not stuck in the 2000s and fear mongering and before you make a decision. Now, I'm not saying every woman needs to be on hormone therapy, but you deserve every woman needs a conversation.
Yes, for
So
sure.
she can make an informed choice for herself.
Right. You talked about the transdermal estrogen. I know that a lot of women take it vaginally to help with vaginal dryness.
So that's
and separate.
exactly.
Is that separate
That's
though?
separate.
Okay.
So, and I love vaginal estrogen treatment.
Right.
The vaginal estrogen is meant to act locally. So think about like you run into Walgreens and grab some cortisone if you've got a rash.
Yes.
Versus taking oral prednisone. When we do systemic therapy, we're treating from scalp to veg.
Right.
I'm stealing Naomi Watts' words from Stripes.
Right.
So we're treating your entire body. When we're treating with vaginal estrogen, it's a very, very low dose, and it's meant to act locally. It's a percentage of what you would get in systemic therapy.
Got it.
So I had I do a once a week, Ask Me Anything on Instagram, and there was a big thread that came out of, I'm using vaginal estrogen. When is it safe for me to have relations with my partner? And I thought, wow, these women don't realize it's such a low dose.
Right.
Unless he has the world's most absorbent penis, it's not going
won't
to.
grow
They are
boobs.
terrified that it's going to give him gynecomastia. I'm like, no.
Right.
I mean, and at first I thought they were asking, is it a lubricant? I'm like, no,
Yes.
vaginal estrogen over time can help you naturally lubricate yourself, but it is not a lubricant. No, we're asking, when is it safe after sex or during, before sex? And I was like, anytime.
Anytime. You're good. He's good.
He's good.
That's hilarious.
Nothing. So anyone can use vaginal estrogen, even with contraindications to systemic.
Right.
No increased risk. Breast cancer, heart attack, blood clots,
None of
nothing.
that. That's just to help the tissue in the vagina to be more lubricated like it was,
And
I guess, in
healthier,
the earlier.
thicker,
Yes.
So when you biopsy a pre and postmenopausal vagina, premenopausal is thick, velvety, lots of mucus glands. Under a microscope, it looks like a mountain.
Yeah.
Okay. Now let's fast forward it 3 years after your menopause. It looks like the Sahara Desert. It is thin, easily friable, but which means terrible.
Which is why women have pain.
Right. And so you lose your elasticity. And so it can be horrifically painful. And I know women who are white knuckling it through relations and absolutely have lost all desire because they hurt.
Yeah.
I'm like, this is fixable.
Right.
This is an easy fix. And once you stop hurting, that libido may come right back.
Yeah. Yeah. We talked about testosterone as sort of a side component to all of this. I know you're more in favor of a lower dose, if at all. When is that a potential factor for a woman?
Sure. So we know that studies in postmenopause have shown that for low libido, which let me clarify that.
Yeah.
Libido is not really a medical term. In medicine, we say hypoactive sexual desire disorder, where other causes of sexual dysfunction have been ruled out. So when we talk about sexual function in a woman and why she may not be happy, okay, I call it, and Kelly and I call it the want to want. If you ever follow Kelly Casperson, she's a magnificent, she's the mage for sexual wellness in women. Okay. And so there's 5 buckets. So we have a relationship disorder. So no amount of hormones is going to fix that. You know?
That's right.
And so you have to have a good, solid partner or someone that you want. You have to want it.
Yes.
And if you don't want it, I can't fix that for you, you know?
Right.
And so then we have desire, which is what happens in the brain. We have arousal disorder, which is what happens in the pelvis. So that is the physiologic response to a stimulus. So that is, you know, sometimes you might have a nerve conduction disorder, longstanding diabetes, you have nerve injury where you're not getting the signals to the pelvis, even though your brain is like, yes, yes, yes. So that's treated. Sometimes vaginal Viagra works for that.
Interesting.
There is an orgasmic disorder. Yeah. So women who either have primary anorgasmia where they've never had an orgasm, and I have patients like that, they've learned to live with it. It's up to 10% of women.
Wow.
If that happened to 10% of men,
it
would be a national emergency.
Yes.
Right. I mean, the FDA would have cleared, you know, and so, and then there's pain. Yeah. So if it's uncomfortable and this is not enjoyable for you, nobody wants to do it. So we need to fix the pain before we address the other issues. Testosterone is good for hypoactive sexual desire disorder, and it's not for everyone. Again, desire is still very complicated. Where I joke with my patients, a man's looks like a light switch, usually on. A female,
it's like a dimmer.
Flight deck of a 747. And so a dimmer switch.
And so
testosterone can be helpful for that.
Okay.
Now I'm using some testosterone off-label with my patients who have sarcopenia. So they have very low muscle mass, and I'm worried about their long-term risk. And they're doing the protein intake and they're doing the resistance training. And testosterone can be helpful there. Now there's some anecdotal evidence, observational studies that are suggestive. Maybe it's great for brain health and some other things, but I don't have enough like clear-cut clinical evidence to blanket recommend testosterone for everyone.
Okay.
We also, thank you, FDA, don't have an approved option for women. So we've got to go to compounding measures often for that. And that's what I do for my patients as well.
Makes sense. Everybody's thinking about HRT for mitigating menopause, but the long-term health benefits, that's what I really want you to elaborate on, because we're not just living into our 50s, but we want to have great lives in our 70s, 80s, and maybe even 90s.
So we're being asked to live 30, sometimes 40 years, average of 30, with no
hormones.
Yeah. From our ovaries
whatsoever. You're going to bury me with a patch on, by the way.
So same. Yeah. And I'm like, no, there's only a couple of species of whales, and I think they just found a giraffe might do it. But like most mammals do not have menopause. Now, there's a lot of the sociobiologists are looking at why this might be and the grandmother hypothesis, but you know, the fact of the matter is very few species live this long without hormones.
Sure.
And I get a lot of kickback from people who are like, well, isn't this meant to be? This is a natural process. Why are we doing this? I'm like, listen, natural does not mean it's not harmful. Cancer is a natural process. Presbyopia is a natural process. Erectile dysfunction is a natural process.
Right.
And no one is coming after the guys for, other than maybe an unhappy partner, for treating that.
Yeah.
And so but besides hot flashes, night sweats, and those do go away. It might take 14 years, but you know,
I wouldn't make it.
We have serious health consequences having to do with our menopause, where we used to enjoy a much lower rate of heart disease. We catch up with our male counterparts. All of a sudden, Alzheimer's, you know, neurodementia becomes a thing that we never had to deal with before.
Right.
And so estrogen, as it turns out, women who go through menopause naturally younger have higher health risks than those who go through naturally older because of the loss of estrogen.
Yes, so early on.
And premature menopause, which is below the age of 40, your risk of stroke dramatically increases, heart attack increases. So the American Heart Association went and looked back at the WHI data, and they said, hey, women who were treated with estrogen early, meaning early into their menopause, have lower risk of cardiovascular disease and lower risk of death from cardiovascular disease. And oh, by the way, lower all-cause mortality.
Interesting.
So there's something protective about estrogen, and now they're calling it the healthy cell hypothesis, whereas estrogen is better at protecting a healthy cell than stopping a disease process once it gets started.
Right.
So there is a window of opportunity for a woman, especially in the neurodegenerative and the heart disease realm, where estrogen might be protective. Now, there was a very recent study that got a lot of press that came out on dementia. And so I've gotten a lot of questions about that recently. So temporally, let's talk about this.
Yep.
Now, God bless the press. There's been multiple articles that have come out in support of hormone therapy in early menopause, being protective for multiple, in studies for neurodementia.
Right.
And they just skipped over those and ignored them and went right to the one that was fear-mongering.
Yep.
And
Hello.
gave it press.
Now you know why I'm not in it anymore.
So here's what I tell patients. Here's when everyone's asking me, there's lots of doctors who have weighed in on this.
Yeah.
Menopause causes dementia. Menopause. Mm-hmm. And a woman who is severe, the only women getting HRT right now are the ones who are severely suffering and basically going in and demanding hormone therapy or they're going to kill themselves, which is how most women are getting it. This is sad but true. Like, I have no option. Mm-hmm. You must give this to me. The more serious your menopause symptoms are, the higher your health risks are.
Yeah.
And so these women are being treated with severe symptoms who were most likely going to develop dementia anyway, is what we're thinking. Mm-hmm. Menopause causes dementia, not hormone therapy.
Right.
They were just happened to have been treated. And they were, so we need this was an observational study, did not prove causation. And we need a lot more money and a lot more research in this area immediately.
Absolutely. Just as we've needed on menopause forever.
Forever. So I want, your followers to do an experiment with me. Go to PubMed, which is a public, where we have like really good medical research journal articles, everything that's vetted and,
so it's published medical information.
Published medical research. Right. And just type in the word pregnancy. Mm-hmm. And I believe the last time I did it, there were 1.1 million articles. Amazing, right?
Right.
1.1 million. That's 1.1 million researchers, research dollars, students being taught. Okay, now put in just the word menopause.
I'm afraid
And when
to ask.
I did it, it was 94,000. Wow. More women will go through menopause than have babies.
Yep.
But that's how our society is functioning. That's how our medical care is functioning. That's where the dollars and the brain power and the energy is going. Why are we suddenly less the minute our ability to have a child
it
goes away?
Gone. Yep. And yet we're the largest growing sector of the population and also the money spending sector.
Yeah.
Things are changing.
Yeah.
And it's conversations like these and dialogues like these and people like you who are saying enough is enough. I spent my time on one side of this and I have seen a huge void on the other. And I'm now placing my emphasis and my time and my care for women who desperately need it.
So
And
So I
so
left
grateful.
traditional OB-GYN to open a menopause clinic.
Yeah.
So I could focus on the people who needed me the most.
That's right.
I have no regrets on what I did in the past, on the residents I taught, on the babies I delivered. I miss them. I get to see them because I live in a small town.
Sure, they're adults
But
now.
now I get to serve women who so desperately need it. Women sit in my office and cry and are just so grateful to be validated and recognized and told it's going to be okay and we're going to figure this out together.
Isn't that great? What a beautiful feeling for you.
It is.
Yeah. I'm so grateful. I want to make sure that everybody can follow you who's listening to us. So we're going to link the book. We're going to link your practice. Is it maryclairewellness.com?
Yeah.
Okay, we'll make sure to link that. And I also want to quickly mention when this podcast airs, you're also launching a meal service that coincides with the recipes and meal planning in your book, which is exciting.
Very exciting. A lot of my followers, patients, are struggling with meal planning or just want some backup, something for backup so they're not reaching in the pantry for something.
Yes.
And so we have a new partnership with a meal delivery service for Galveston Diet, and that is so proud of and so excited for people to be able to take advantage of if they need it.
That's awesome. Well, thank you for making the drive into Houston today. I'm
Thanks
so
for having
glad.
me.
Oh my gosh, anytime. There's so much to talk about. I feel like I can have you back 100 times and there's still, more hours to discuss. But we're scratching the surface and I appreciate that. And I appreciate you and what you're doing for women in midlife.
Thank you.